State President Dr. Narayanan, National Vice President Dr. Ananda Keshavan, respected teachers, colleagues and friends, and guest of the day, our own Menon sir. Today, fourth talk of Beyond Horizon DOYENS series. Today, PSN Menon sir will talk on newborn thyroid screening. Where do we go from here? Menon sir needs no introduction to this audience. He said belongs to 10th batch of Calicut Medical College. He did his postgraduate degree from All India Institute of Medical Science, New Delhi, and worked there and retired as Subdean and Professor of Pediatrics. During that tenure, he was the consultant in charge of the endocrinology as well as the genetic clinics. And he wrote several books. He's the editor of 4 books in the pediatric endocrinology as well as the adolescents. Now he's working in the Jabir Al Ahmad Armed Force Hospital at Kuwait, and he's the past president of the Endocrinology Society of India. With a lot of regards and respect, I welcome you, sir, to this webinar.
Thank you.
I also welcome our state president, national vice president, state secretary, my respected teachers, colleagues, and friends to this webinar. I also welcome my team at Calicut, Dr. Vijay Kumar, Dr. Ranjit Nihas, and scientific committee coordinator, Dr. Ramesh, and all of you to this webinar. This session is chaired by my respected teacher, Dr. C.K. Shishran sir. To save time, I am not going to say more about him. And to save time, our state president, Dr. Narayan, already asked me to convey his best wishes to this webinar. And he also conveyed his regards to Menon sir. With these words, I request Dr. Ananda Keshavan to say a few words.
Am I audible, Ashraf? Am I audible, Ashraf?
Yes, sir.
Yes, you are audible. You are audible.
Very good evening, President Dr. Ashraf, respectful Chief Guest Menon sir, my teacher Dr. C.K. Shishran sir, and other senior colleagues, Dr. Ramesh, Dr. Vijay Kumar, Dr. Nihas, and all other IAPs. So very happy to see that Menon sir again. I think he's one of the best endocrinologist teacher, academician, and a very good human being. And I think 3-4 days before also we had some meeting with Dr. Menon sir. I don't know Menon sir working in Kerala or not. I am always we call him as external faculty. Because, sir, have you working in Kerala?
Yes, I have worked for 1-2 years.
Oh, that's so.
Tutor in IAP Medical College.
That's it.
Before I went for postgraduation in AIDS.
So yeah, everybody is eagerly waiting for you. So I am not extending my speech further. I wish the program all the best. Thank you. Jai Hind, Jai IAP.
Now I invite Dr. Ramesh, the Chief Coordinator of the Scientific Committee of this program, for opening remarks.
Respected President Dr. Ashraf, State President Dr. Narayan, Secretary Dr. Bala, Office Bearers of IAP KOZHIKODE, South Vice President, Chief Guest of the Day, and our dear beloved Dr. Ananda Keshavan. Guest speaker for the day, Dr. PSN Menon, chair for the day and senior academician and teacher of teachers, Dr. Shashidharan, Dr. Shaji Thomas, Dr. Parvati, and all my senior friends and fellow academicians. Another exciting evening when we are having Dr. PSN Menon sir with us, a man who is considered to be another the doyen in pediatric endocrinology. And for me, I was quite fortunate to work with sir for so many publications, especially in Dr. Patsari research textbooks. At least I believe some 8 to 10 textbooks I worked with him. And he's such a, he's known for his academic brilliance and is the meticulous nature, the way he is being an army man, or possibly the way he moves with everything. Everything has got such a disciplined and structured approach. And that perhaps that has taken him so much in his life, and still he remains so young and energetic, possibly because of that, the way he moves about with his life. And for the to chair the session, we have got Shashidharan sir here today, and he is another, possibly after Rajagopal sir, the great teacher from Kozhikode, and Shashi sir is always there with us, IAP Kozhikode, but then he is here to give his wisdom, also wisdom for this session. And I believe the Doyen of Pediatrics series is going great with a lot of captive audience from outside the state also. In fact, I was quite surprised to see a good many number of our friends joining last time also for this webinar. And even for today, I've seen a good many friends from, because I can pick up many of them from outside Kerala who has joined. And even Dr. Srinivasan is there from Pondicherry. He has asked me when is Dr. Menon's talk. And he's also here. That's quite encouraging for IAP Kozhikode. The best wishes. IAP Kerala and IAP Calicut going in great way. Congratulations, Dr. Ashraf, Dr. Nihas, and the whole team behind Dr. Vijay Kumar and Ranjit, Mohan, and the whole team at IAP Kozhikode for this, who are conceptualizing this webinar series and moving ahead in full steam. Best wishes for the webinar and great going IAP.
Thank you, Dr. Ramesh. With this, we are going to the scientific session. Today's session is on newborn thyroid screening. Where do we go from here? The speaker is Dr. PSN Menon. I invite my respected teacher, Dr. C.K. Shashidharan sir, to chair the session.
Thank you, Dr. Ashraf, and the office bearers of IAP Calicut for bestowing an honor on me to chair a session which is going to be enlightening all of us by none other than my close friend, Dr. Shankara Narayana Menon. I knew him almost as an undergraduate. Then I met him at All India Institute. We worked in the same ward, under the same department head who nurtured, who molded, and he groomed all of us how to become a good pediatrician and a good teacher and a good medical writer, which Menon is exemplarily writing most of the articles that we come across. Going back to some more days in the institute, both of us, we heard Professor Ramalinga Swami coming and telling about thyroid problems in the Himalayas. We were wondering how he goes to Himalayas and collect all these details. And that was followed by none other than another Malayali, that is Dr. Kochipillai. He continued at the institute. Of course, they were very, must be in league with Dr. Menon, and he did a lot of screening tests, which those days men did not start the community screening. And I was part of it and sending samples from here to Professor Kochipillai. Then at that date, we got 2,500 samples. There are only 4 found to be hypothyroid. So I think the genesis of this thyroid abnormalities and interest on hypothyroidism must have been instilled in him from the institute itself. And he continued and he continues. And I know that he has been doing excellent work, and by maybe the fate, he happened to serve more people in Kuwait than more people in our country. But it doesn't matter. But he is indirectly helping the whole nation by teaching a lot of students on endocrinologists. He also was in charge of the genetic units, which all of us knew. All of us went with Dr. I.C. Verma. When he retired, he was in charge of the genetic unit also. All these centers were in collaboration with WHO, and we had an excellent exposure And once I went to UK, I came to know that he has visited, he came with a patient from there to UK for a detailed discussion with the Dr. Ajit. He's from Malappuram. I stayed with him when I visited for a conference. So he's known not only over Kerala, he's a son of our soil, and he's known all over the country, and also his expertise and advice now spill over to the rest of the country or even to the world. And I know him, his family, everything is known to me, but it's very difficult to meet personally. But this Zoom business following the COVID has made us to meet more than what we used to have in the olden days. When I visit institute, I used to see him, and I used to go to his quarters when he was staying there. So those are the old days. Then now he has left. He is in Kuwait, and he is doing extremely well. And in fact, I follow all the writings which comes in Indian Journal of Pediatrics and Indian Pediatrics on thyroid problems in children. And I will not prolong my talk. And you're all eagerly waiting for him. Myself also waiting for him. And my dear friends and colleagues, I present Dr. Menon for this talk. Thank you, Dr. Menon.
Thank you. Shall I start?
Start.
There's my to get my sharing. Vijay, can you help me with the sharing of the screen?
Thank
It's
you.
not coming through.
Thank you.
Sir, sir, can you go back to the Zoom mode?
Yeah.
Yes.
Sir, can you retry?
Annallo.
Sir,
Yes.
that is correct, sir.
Yes,
Yes.
connected, but I'm not able to get my slides.
Sir, you can just make it
I don't know.
full screen.
Yes.
I think there's some problem. Sorry for that.
So no need to go for Zoom again. You can just directly open. Your screen is already shared.
Yeah, but I'm not able to share the slides.
You can just open the slide, sir. That's enough.
Yes, slides are
Yes, sir.
open.
Yes,
Yeah.
your slide is
Oh yeah, it's open.
just make it full screen, sir. Yeah, just make it.
Okay, sir.
Yeah.
It's open.
Yes, sir.
Yeah, sir.
Yes. Shall I start? Can I start?
Yes, sir.
Yeah. First of all, I'm sorry for this delay. My apologies to everybody. My special thanks. At the outset, I would like to thank IAP Calicut as well as IAP Kerala for giving me this opportunity to be amongst you and share my experience with you all. My special thanks to Dr. Ashraf, Dr. Narayanan, Dr. Ananda Keshavan, Dr. Ramesh Kumar, Dr. Balachandra and Krishnamohan, and also to my dear friends in Calicut, especially Dr. Vijay Kumar and Dr. Riaz from Trivandrum, with whom I had spent a lot of time discussing about today's presentation. The discussion about today's presentation actually came from a stimulus provided by my erstwhile colleague, Dr. Shashidharan, when he made a comment about missed cases of hypothyroidism following newborn thyroid screening and how we should manage these problems in the best interest of patients. So I would like to start from what he said, and we has titled this talk as to where do we go from what we are doing now. To make that appealing to you, I have taken a lot of help from my colleagues from the Indian Society for Pediatrics and Adolescent Endocrinology, which is the chapter of IAP for Pediatric Endocrinology, which includes my erstwhile colleagues, Dr. Meena Desai, Professor Raghupati, Professor Vijayalakshmi Bhatia, Professor Anju Seth, and a number of colleagues who have actually gone to make the ISPAE guidelines, of which Dr. Riaz from Kerala is also a co-author for this presentation. I am also especially thankful to Dr. Vijay Kumar from Calicut and Dr. Riaz from Trivandrum, who are the nodal officers of the newborn screening program for thyroid and related diseases under the National Rural Health Mission. I think it is NRHM Kerala, which is probably the first state to start a nationwide screening program for not only thyroid, but also for other diseases, and is acting as a model for all neonatal screening programs in the country and for probably rest of the world as far as developing worlds are concerned. So without wasting more time, I'll go into the specific talk. Now today we are discussing about hypothyroidism because it is involving screening. We are discussing about congenital hypothyroidism. It has an incidence as high as 2000, 1 in 2000. It is not only the most common cause of preventable intellectual disability, but also the commonest endocrine disorder that affects children. So it has two imperial positions as far as pediatric endocrinology and development are concerned. The curious problem about this particular case, as you can easily diagnose from the slide that you can see on the left side, is that by the time pediatricians make the diagnosis, the child is pretty old and probably the neurological abnormalities are already established. Less than 5% of babies are symptomatic at birth, and only up to 10% may show symptoms in the first month of life. So the greatest window that we can intervene for this child is already lost if you have no screening measures are available. And you can have a near normal outcome if you can diagnose this condition and treat it before 2 weeks of age. So that is the most important aspect of congenital hypothyroidism. We knew almost five decades back that congenital hypothyroidism is associated with a poor intellectual and cognitive outcome. IQ studies and developmental studies had established as early as 1972 that if the child has been diagnosed to have hypothyroidism as late as 6 months, the mean IQs are near 54 to 55. And if you can make a diagnosis very early, you can actually make the outcome, the cognitive outcome or the intellectual disability much less. And that was the earliest method by IQ studies that they have found out, and which became the forerunner for development of early diagnosis and early treatment of this condition all over the world. So it is actually a typical example of a case of a disease for which a newborn screening can be established. At this moment, as far as the newborn screening committee of the WHO, as well as the National Health Institutes of USA, there are 43 conditions for which newborn screenings are available. It includes several other endocrine disorders, neurological disorders, inborn errors of metabolism. But the standard platter for which a diagnosis for or the provision for newborn screening is made is exemplified by congenital hypothyroidism. It has got a reasonably good incidence. For example, in India, we know that it occurs in 1 in 1,000 to 1,500 newborns or births every year. You have a screening method, for example, estimating the levels of TSH, which is cheap, which is easily available all over the country. And once a screening is done and a diagnosis is made, there is highly effective and yet inexpensive treatment available for this condition. And it has been proven by multiple studies and observations that the benefit of treatment for this condition is at least 10 times more than the cost of screening by cost effectiveness studies. This is done not only in India by multiple observation, but all over the world. So it is a standard example of a case for newborn. When you are thinking about newborn screening, you are trying to do an estimation at as early as probably at birth or immediately after birth. So you have to know whatever element that you are going to estimate for the diagnosis of the condition should be available in reasonably good levels in the blood or the screening material, whether it is a saliva, whether it is a urine or any other body fluid. Typically, we know that hypothyroidism is essentially a lowering of the levels of thyroid hormone, that is T4. T4 is primarily converted into peripherally into T3. So estimation of T4 is preferred for detection of congenital hypothyroidism. But since this condition is characterized by lower levels of T4, estimation of lower levels of T4 requires very sensitive and specific assays. In this case, we generally use the TSH, which rises with hypothyroidism and is easily detectable in the blood. Unfortunately, immediately after birth, the TSH has a surge going up to as much as 80 international units or MIU per ml per liter and rapidly comes down by the end of second day to near normal levels or levels at birth. Even at birth, immediately after birth, the levels will spike in seconds and minutes. So the test has to be done probably either in the cord blood or after the surge of the TSH immediately after birth, which is around 48 hours or later. You can see that the surge of TF4 following the TSH takes a slower course. It keeps on going high for the first 24 to 48 hours, but does not touch normal even for the first 5, 6, or 7 days. So if you are going to use an assay for detection of T4, it has to be one at birth from the cord blood or relatively later in the days. So these have practical issues in the choice of the test that you do and the method that you apply for newborn screening. As exemplified in the previous graph, you can see that the cord blood avoids all the problems of surge and has got nearly normal levels. If you have to avoid the surge, you have to and get back to the normalcy for TSH, you have to use the 24 hours of the sample of after birth. If you have to use T4, you have to wait after 72 hours. But you have to note that TSH and T4 can remain elevated for several weeks, even in normal children, giving false high values and false values for T4. And cord blood samples are not affected by TSH, sir. So cord blood screening would be easier in at least technical language. And we have to realize that postnatal samples collected before 48 hours can have high false positive rates because of this particular physiological phenomenon. Second part of the practical aspect of hypothyroidism is congenital hypothyroidism could be either due to an abnormality either in the thyroid, or it could be an abnormality in the controlling hormones produced by either pituitary or by the hypothalamus. So 75 to 80% of all causes of congenital hypothyroidism are permanent and are due to either dysgenesis or agenesis of thyroid. And ectopic thyroid would probably, as years go by, it will be probably the most common causes of hypothyroidism in relatively older children. Dyshormonogenesis is relatively rare. Some transient causes can also be there, which will disappear over a period of time, which will make the diagnosis of congenital hypothyroidism difficult. Other causes like thyroid hormone resistance are relatively rare, but these have to be kept in mind whenever we make a screening strategy for the congenital hypothyroidism. The other principle of newborn screening is that in inverted commas, it is screening and it is not diagnosis of congenital hypothyroidism. We are trying to make a screening for congenital hypothyroidism so that we can make an intervention for prevention of mental subnormality in these children. If that has to be done, the screening result should be available to you before 14 days of life. That is why newborn screening program is important. That is why we say that diagnosing children at 1 month or 2 months will not serve the purpose if your aim is to prevent cognitive as well as neurological abnormality. So we have two proposed mechanisms to do newborn screening. One is to collect samples in cord blood, or the other one would be to do a heel prick blood sample taken on a filter paper after 48 to 72 hours. Technically speaking, cord blood sample would be an easy method because you are not pricking a baby. There is no pain involved. It is also possible to do cord blood after each delivery. And if the plan of the obstetric unit is to have early discharge of babies within 24 hours, then probably we are not losing babies. We can get all babies screened and suitable for the samples can be collected in a vacutainer and they can be processed in any lab which is processing a normal blood sample. However, there are 3 or 4 problems that can come with cord blood sampling because it has to be collected after every delivery then the collecting staff or the protocol has to work 24 hours a day. And also you have to train the staff who is collecting the sample and transferring to the lab the protocol for how to collect sample and send it and then mark it very meticulously. Another problem with cord blood sample is we are not screening not only hypothyroidism but also several other inborn errors of metabolism. So they cannot be used or screened by cord blood sample. For example, if you are going to screen for maple syrup urine disease, PKU, or galactosemia, it is essentially that these will be established only after normal breastfeeding is established and feeding is established. So cord blood would not be a good material for assessment of most inborn errors of metabolism. However, it will be a good sample for hypothyroidism. This problem is avoided by postnatal heel prick, where you can screen multiple disorders with one sample. You can collect samples on all babies in the morning, collect them all after, because they are all available in the ward in the morning. And then you can train your staff, whether there is a student, whether it's a postgraduate or a healthcare worker, to do the screening under your monitoring. How? The problem would be that the filter paper samples, or what we call as the DBS, direct blood spot, will need a special assay and a central lab where these can be assayed. And then there has to be a communication between the lab to the treating unit and with the families, especially the mother of the baby. So it is possible to do this with a well-established healthcare surveillance system coupled with screening. So this is what is preferred in most setups. You may ask me why I cannot take blood sample from cord blood. The baby has to go for some reason before 48 hours. What do? You can also take a postnatal venous sample like we do for collection of blood for a sick baby. We can also do it on a vacutainer collected sample if filter paper is not available. But we would not prefer undue bleeding or invasive techniques and if it is not necessary. So all of you are probably in Kerala familiar with the different methods of how we do a heel prick. For those not from Kerala and not seen how a procedure is done, it is better to see a video. The person who is collecting blood should have a protective gear, including gloves. You have to clean up the sole. You have to make sure there is enough blood circulation, and with a lancet you can collect. A clean blood spot is collected, then it is transferred onto a filter paper which has got multiple methods. You have to avoid overlayering of the samples. One sample, if it is not taken properly, you can do it on the next 5 more samples. So you are not losing samples. Once it is collected, which has got all the details of the baby, it is air dried and kept stored one of another, and before it is being sent to the central laboratory where it is established. It is also important that all the details related to the baby and the mother are also recorded on the associated filter paper information paper. That is also is equally important, which includes address as well as the phone number of the mother or the father who is of the child who is being screened. So to come back, most of the samples are collected between 48 to 72 hours. It can go later, not more than 5 days. Samples collected on 6th day and 7th day and later would have different cutoffs and different values. You may ask me, suppose the baby has to be discharged early because of some specific reason. Then you can collect samples between 24 to 48 hours as well. But you cannot use the same cutoff which are using for 48 to 72 hours for the same values. There are separate values. For this, we will discuss about it a bit later. You may ask me, is it applicable to all babies? Suppose it's a preterm or is it a small for gestational age baby? The protocols are the same. If the baby is not sick, all of them would be evaluated at the same time as per any term baby. If the baby is in an NICU or has got a transfusion for another reason or some intervention which has to be done, then the samples are to be collected before 7 days of life, or even in this case, as a special case, it can be discharged even after 7 days. Also, you can collect the blood, but the interpretation of results will have to be made depending upon the age of the baby at the time of collection of them. The purpose of saying this particular statement is that there should be no reason to deny newborn screening for a baby. Every infant should be sent home with screening. And even if it cannot be done at 48 to 72 hours, you can do it in a special case early. And if it is very necessary, you can even do a bit later. Now comes to what are the tests that you prefer. I told you a bit earlier that you can do a TSH-based testing and T4-based testing. Primarily, if you look at the diagnosis, low T4 is the primary diagnosis for hypothyroidism. So technically speaking, T4-based screening with or without TSH back should be more diagnostically oriented than screening. But for screening, we prefer TSH because the assays are most sensitive. It is the currently used assays, immunological assays are almost 97% sensitive and 99% specific for the diagnosis of CH. So it is a good screening method if you are going to look for TSH-based methods. The only problem is, since TSH levels could be either low or it could be very almost near low normal levels, it may miss pituitary and hypothalamic causes of hypothyroidism. Also, there may be some newborn babies who may have a delayed surge with a delayed rise in TSH and T4, and we may miss them if we are not very careful about them. So it is not 100% sensitive, but it is a very sensitive assay. T4 assay will confirm the diagnosis, but however, it has very many high false positives, and it will also miss compensated hypothyroidism where T4 levels are low, but TSH levels can be normal. So you have to do tests based on what you are going to do. From what I said till now, you must have understood that a secondary sample for confirmation of diagnosis is needed for diagnosis. So in most situations, once the screening is positive for the diagnosis of CH, a second sample is connected between 2 to 4 weeks. In most advanced centers, it is collected within 2 weeks because we want to start treatment as early as possible. But in many situations, it is probably where the babies are preterm, IUGR, sick neonates, we will probably may be able to do even as late as 4 weeks because we do not want to miss these children. The next question is, if you are going to do these tests in a central lab, which assays are going to be used? These serum samples, if you are going to do cord blood, you can do it in any conventional laboratory using either enzyme-linked immunosorbent assay or a chemiluminescence assay, which is routinely available. And you can get the report in 24 to even as early as 12 hours reports. But if you are going to do a filter paper DBS, you will have to do either a immunofluorescence or a calorimetric method in a central laboratory, which is tuned to work with filter paper cutout samples. Since it is being done in whole blood, the estimated value is usually expressed in whole blood units. Whole blood units are different from what we usually express as serum units. If serum units are to be expressed, the whatever value you get in blood units has to be multiplied by 2.2. In the old system, the values used to be expressed as whole blood units, and when a value of 2.2 MIU units per liter was expressed, many people used to misunderstand that this is normal, because 2.2 multiplied by 10 will be equal to 22 MIU per, sorry, 2.2 into 2 will be 4.84. It is nearly 5. So if the value is 10, it will be 10 into 22, which will be high. So now most laboratories, whether they are central or even peripheral, they report in serum units and not in blood units to avoid this confusion. However, it is important that you check with the laboratory with which you are coordinating about the units in which these are being expressed. Now, in India, newborn screening is not a new thing. It was there. However, as a national NBS program is not yet there. It is only in only few states like Goa and Kerala that it has started in full swing. Some of the states like UP and other states that started earlier but had to discontinue temporarily for some reasons. The first reported NDS program was from Bombay, from Vijayawada Hospital in 1982. The longest standing newborn screening program is from Vellore, which is almost 2 decades old. Now here is a summary. I don't want you to strain your eyes, but I just want to show you two important aspects. It all began with cord blood in the first phase, but over the years, everybody has moved to filter paper based direct blood spot for TSH. In all over India now, TSH is the preferred method for assay for the detection of or screening of hypothyroidism. The cutoff values have changed over the years. In the first report of Dr. Desai et al., it was more than 30 were used as a cutoff. The largest study published in multi-center from Chandigarh, it was 40. But you can see that over the years, most centers are using 20 as the cutoff unit for newborn screening. The last row in red bold prints, I have just given the data provided to me by Dr. Vijay Kumar and Riyaz. In Kerala, almost nearly 1 lakh children newborns have been screened, and the cutoff used is 20 milli-international units per liter. The test used is a direct blood spot on filter paper, and the assay used is TSH by an immunofluorometric assay. And at the moment, the recall rate is less than 1%, and the incidence of congenital hypothyroidism in Kerala appears to be 1 in 1,200. So it is higher than what is reported in rest of the world. So to summarize, a value of more than 20 milli-international units per liter is usually taken as the standard. All neonates with a positive screening results are recalled immediately, and a confirmatory testing is done by measuring serum concentrations of both TSH and either T4 or free T4. I would prefer free T4, but free T4 assay is little more expensive, so many centers prefer a total T4. The results which you get on the repeat assay, since the children would have become older, maybe sometimes as old as 2 weeks and 3 weeks, has to be interpreted based on the gestational age and postnatal age-specific ranges, which are available with your central laboratory. So what are the Indian protocols for studies? These have been made up by a consensus guideline report, which is published under the banner of the Indian Society of Pediatrics and Adolescent Endocrinology. It is available to you all as two publications in Indian Journal of Pediatrics in 2018. Once again, let me point out your colleague, Dr. Riaz, also is a part of the team which has been writing this. The second part, first part tells about screening, and the second part discusses about the management. In a nutshell, if you take a sample of from the heel prick, what you are going to look at is whether the levels of TSH is more than 20 milli international units per liter. If it is high, then the child is called back and a repeat TSH and T4 or FT4 is done. If the repeat sample has high TSH persisting, whether it is with normal T4 or T4, you have to repeat TFT after 2 weeks. And if the TSH remains persistently elevated, the child is started on treatment with L-thyroxine till the child is followed up as per schedules that we will say in a few minutes time, till the age of 3 years, when the brain development is complete and the child has attained full developmental capabilities. If the TSH is high and there is low T4 or FT4, then you are not confused at all. You are sure that the child has congenital hypothyroidism. Here the question is, we have to find what is the etiology of hypothyroidism. Ideally, this can be done by imaging, which uses an ultrasound or a nuclear scan. But if thyroid imaging is possible, that helps you in counseling and confirming the duration of treatment, whether it is a lifetime treatment or not. But however, since imaging may not be available at all places, if it is not possible, it will be better to start treatment with L-thyroxine till the child continues to have follow-up. And if the child has got borderline high TSH or T4, he will continue to receive treatment till the age of 3 years. If the child has a normal TSH, then obviously we think that the child is normal. But many of these children may have a low T4 or low FT4. The usual reason for this is actually the child may be a preterm. The child may have hyperproteinemia because the thyroid hormone T4 is bound to proteins, especially a specific protein called thyroid binding globulin. So situations in which the child have low thyroid binding globulin, or the child can have low T4. So ideally it will be better to do FT4 assay in these children. Fortunately, this condition does not produce hypothyroidism and mental subnormality. So this is the simple principles of management of children with following screening. I said about confirmation of imaging because to start treatment in a child who looks otherwise normal and does not have any features of hypothyroidism, with treatment at a very early age, especially when many pediatricians and adult endocrinologists have concerns about the adverse effects of starting L-thyroxine at a very young age, many people prefer to do imaging. Image can be done even in after the CH is confirmed by the second test. Scintigraphy, that is a nuclear scan, can be done up to 7 days even after starting L-thyroxine. Ultrasonography can be done even later, so it is not a problem. But the diagnosis and treatment should not be delayed waiting for the test to be done. Ultrasonography is relatively easy, but it requires a radiologist who is good at doing ultrasonography in newborn babies with a short neck, Also, sometimes it is very difficult to pick up an ectopic thyroid gland with a conventional ultrasound. So most people prefer combining ultrasound with a nuclear scan. Nuclear scan, one general worry is that radioactive material can damage the thyroid as well as the rest of the body tissues which are under development. But radioactive materials like technetium are relatively safe and quickly removed from the body. And they can very easily pick up an ectopic thyroid or complete absence of thyroid tissue and in the neck very easily. And even sometimes you can pick up a goiter which was not easily seen, as seen in children with dyshormonogenesis. Now, in advanced countries, you can also do a SPECT CT with using technitate, and you can easily see a ectopic tissue. But these tests are available only in a very few centers in the country, so it is not routinely recommended. They have only a research value. So the next question is, you have already done the screening. You have got a lot of patients which has got high levels of TSH. This one question is that whether we are likely to miss children with congenital hypothyroidism with this protocol. Misdiagnosis is common, even in the well-developed Western centers. After a review of 30 years of screening in Pittsburgh, which was the mother for all newborn screening for hypothyroidism, as well as in Quebec, Canada, they have realized that it is impossible to pick up 100% all children with hypothyroidism by newborn screening. Even in the Western centers with highly sensitive assays and acute management for every situation, 1 to 2% of children, newborns with congenital hypothyroidism are missed. This has been published as late as 2018 from USA. So don't be under the misimpression that we will be picking up all cases of congenital hypothyroidism with any sensitive specific assay done in newborn period, whether it is on a dry blood spot or whether it is on a cord blood. But what the researchers advocate is that it is better not to miss. So you have to make specific cutoff to by review of the assay techniques and the results periodically. And also it depends upon the pediatricians in the general population who pick up these missed cases at a later age to inform the surveillance screen as well as the newborn screening team that you have missed that case so that they can go back and check the assay as well as see what really made this test abnormal. In most cases, it has been found that it is sampling error and improper recording of the time of birth and collection of samples that has led to this missing of mild persistent hypothyroidism. You may also ask me, are we overdiagnosing? We have got too many assays and then probably we are overdiagnosing the assay. I can exemplify this by the examples of the data which Dr. Vijay Kumar has provided me from Calicut. When they started the program in 2013, the initial screening could pick up 31 cases with high TSH, but only 4 were confirmed to be truly congenital hypothyroid. So you may ask me, 27 were wrongly diagnosed, they had a second prick, and maybe they had a third prick as well. But you see, as the experience increased and laboratories become more specific and sensitive with the assays, you can see that as late as 2018 and 19, this has probably become almost equal and the screening has become very sensitive and specific. So you are not over-diagnosis and over-recalling children with newborn screening. That obviously means that you should have a continuous surveillance system. The main purpose of doing screening is not just to detect hypothyroidism. That could have been done by testing at any other time. The main purpose is to prevent a neurocognitive damage to the baby. So I told you a little earlier that this can occur only if you institute treatment before 2 weeks after birth. So if you have to really prevent neurocognitive delay, intellectual disability, you have to do newborn screening meticulously and have the reports early enough to introduce treatment early enough. Unfortunately, there are over 2,000 publications on newborn screening, but long-term studies of children who have been diagnosed and screened for newborn screening and of following them for 3 years, 10 years, or even into adulthood to see whether they have any specific neurocognitive delay are very scarce. They can be are very few long-term, well-established studies. They can be numbered on that. This is because follow-up of children with hypothyroidism is not easy. So my earnest request to the Kerala team is you should follow up every single child with hypothyroidism that is screened and diagnosed. Follow them up meticulously at 1 year, 2 year, 3 year, and see whether they are developing cognitive neurological delays. If you are under the impression that we can prevent the neurocognitive delay 100%, that is also wrong. We have seen that it can decrease the number. Over the years, Pittsburgh and Quebec have shown that the neurocognitive delay as high as 8 to 28% comes down to 1%. So mild neurocognitive impairment is still be there in all systems of NBS programs for several reasons. Number one, the callback day for reviewing and confirmation will be late. Parents may not be giving the medicines correctly. Follow-up and re-evaluations are not happening at the way it should be planned. So all these things are contributory to the development of neurocognitive delay. Just screening and diagnosis is not enough. So you need a good surveillance follow-up system with meticulous follow-up of these children, not only for hormones, but also for neurocognitive development, also for evaluating that they are taking the medicine. The medicines are given at appropriate dose, at appropriate time for the appropriate length of time. All these are important. And also, we always see parents, when they see children are normal, try to discontinue under some explanation or advice from other systems of medicine or even from among ourselves. They discontinue medicine to retest. So these things should be avoided if you are trying to make sure that the baby is intellectually normal. Some critics have even asked if you are starting L-thyroxine at a very early age, when the child has not manifested congenital hypothyroidism, are you not probably making the child a bit hyperthyroid? Will these children develop features of hyperthyroidism? Will these children develop features of attention deficit hyperactive disorder, autism? These have been in fact evaluated in several studies, and some of them have actually found that reduced IQ, attention deficit, mild language and visuospatial impairments are common even after diagnosing. But whether it can be attributed to therapy is not proven as yet. So the reasons for the neurocognitive impairment is essentially mostly postnatal factor. Prenatal factors like established hypothyroidism in the pregnancy or maternal hyperthyroidism manifesting with antibodies damaging are probably things which probably we cannot probably intervene at this moment. But definitely postnatal factors like late diagnosis, adjustment of TSH cutoff values after 2 days, starting the treatment early, ensure that the thyroid function reports to normal early enough, avoiding under or over treatment, ensuring that there are follow-up clinic visits, ensuring support from the parents about the disease, and also improving our own communication about the management and diagnosis of hypothyroidism. Also, it has been a good observation that neurocognitive disability probably is proportionate related to the amount of hypothyroidism as seen by the lower level. If the newborn has extremely low levels of T4 and extremely high levels of TSH, then these children are at risk for a poor neurocognitive outcome. And the neurocognitive outcome is especially more with one particular congenital form of hypothyroidism, that is thyroid agenesis. Ectopic thyroid and other groups generally have a relatively good outcome. So to prevent neurocognitive poor outcome, there is a need for early and prompt treatment as well as more frequent monitoring to ensure that the thyroid function returns to normal. This was re-evaluated by the European Society for Pediatric Endocrinology Consensus in 2014 with a meeting of members from all pediatric endocrine societies of the world, including our own Indian society. And at that time, I was the president of the society. And we were represented in this consensus by two esteemed members, Professor Raghupati and Professor Anna Simon from Vellore. And they made a very clear observations about not only screening, diagnosis, and management of congenital hypothyroidism. I will just highlight a biggest observation is the early treatment and initial high dose of L-thyroxine rapidly normalizes thyroid function. And this dose may probably increase T4 levels to even supraphysiological levels. But still the outcome would be better. So the ESPE with all other societies recommend that the thyroxine dose for a newborn child is somewhere in the range of 10 to 15 microgram per kg per day as soon as possible. This is compared to the 5 to 6 microgram per kg per day that you would be giving to a child who is 1 or 5-year-old. So relatively, these children will receive higher doses at an early age. Giving minuscule doses of thyroxine does not help you in normalizing thyroid function and avoiding neurocognitive dysfunction. And the second part of this normalization means that you have to ensure that thyroid function returns to normal. So you have to have more frequent assessments. This is where probably we will have fights with the family, especially the mother. You have to repeat the T4 and T or at 2 weeks, and thereafter at 1 month, then every 2 months till 6 months of age, then every 3 months till 3 years. After 3 years is the time to stop treatment and reassess if you wish to. Assessment is not just assessment of hormones. Assessment includes assessment of growth and development. So the Indian guidelines, which we have recently published in the Journal of Pediatrics, take into account all these factors. Treatment Imaging should be done by radionucleic scintigraphy and ultrasonography if you have confirmed the diagnosis of congenital hypothyroidism, but it should not be unduly delayed. We also recommend levothyroxine in a higher dose of 10 to 15 microgram per kg in the neonatal period. And we also recommend more frequent monitoring of thyroid hormones in all these babies. And we also recommend discontinuing treatment only after the age of 3 years if planned for decision about lifelong therapy. This is just a table which shows the daily dosage of L-thyroxine which is advised for these children at different ages. You can see that the dose that we recommend in the first year is definitely higher, and it is brought down based on the T4 and TSH values to lower doses as the child grows. So I have summed up the most of the details related to the congenital hypothyroidism. Since we have already gone from establishing a congenital hypothyroidism screening program, which was established in most medical colleges, now I think Kerala is on the threshold of starting or expanding the programs to all regional centers with all district hospitals and, if necessary, all private centers as well as taluk hospitals where deliveries are taking place, ensuring that even babies born outside or at home are also brought for evaluation of thyroid screening as far as possible to the nearest center where this can be done. So I will break and then show you some case scenarios just to explain what I have told you about the diagnosis and management. Here we have a premature baby who was found to have a TSH of 18 MIU per liter. I told you a bit earlier that the cutoff for the diagnosis and screening and recall is 20. Should we let this child go back home and come back, or no screening further? Since I am not in an audience and cannot get answer, I would say most premature babies have an attenuated surge of TSH immediately after birth. So we do not usually see TSH peaking to 20 or even to 40, and even very, very rarely more than that immediately after birth. So a low levels of 18 does not really rule out a normal surge has really taken. It could be either the TSH is low or the TSH has not gone to the required higher level. It may go on after a period of time. What could have been the reason for this delayed surge? It could be that the baby had some other problems like sickness. Maybe the child had septicemia. The baby may have had a respiratory distress syndrome. The baby may have been administered drugs which have an impact on the child's thyroid system. Even sometimes the baby may have had a multiple applications of iodinated antiseptics on the body for several procedures and other reasons. These could be absorbed from the skin and have an effect on the hypothalamo-pituitary axis. So we have to look into the history instead of just planning disease as normal. If the TSH may not be as high as normal during the initial few days, it may rise subsequently. It could be delayed elevation of TSH. So this baby does require a second sampling at around 7 days to confirm whether it is a delayed rise in TSH. So the baby needs an evaluation, but we would not label this baby either as normal or as a child with borderline hypothyroidism. However, this would also need a confirmation with a level of T4. this baby, when followed up on 25th day, he could not be followed up earlier because of illness and other reason. On 25th day, the T3 TSH has come up to 23 milli international units. And the total T4 levels is 6 microgram per deciliter. Just for those who do not have normal values, T4 6 microgram per deciliter is a relatively low normal level of T4. The baby is now 25 days old. Does this baby need treatment for hypothyroidism? As told earlier, the T4 levels are low. The T4 level in a preterm baby could be low because of the baby may have hypoproteinemia, or the baby may not have sufficient amount of thyroid binding globulin, or what we call as hypothyroxinemia of prematurity. So how do we confirm that? The confirmation is by looking at not total T4 levels, but by free T4 levels. So if we do a FT4 level and the FT4 levels are normal, then we do not need to intervene at this moment. So ideally, second sampling should more, if possible, should be a free T4 rather than a total T4 level. I understand total T4 is relatively cheaper than free T4 levels. You may even ask me, the level of 23, it is also high. Yes, here you have to look at, when we say 23 and 20, the cutoff of 20 that I have spoken to you is for newborn screen sample. This baby has grown to 25 days. So we have to have age appropriate cutoff values for TSH for diagnosis. So cutoff is that if the baby is less than 14 and if it is about 20, it is high. It is still high. And if the baby is more than 14, the cutoff goes down to 10. So from this angle, this child has elevated TSH, and if the child has low levels of FT4, this child should be put on LT4 therapy, that is thyroxine therapy. And ideally, this child will be benefited with an imaging which will help you to diagnose whether there is dysharmonogenesis or ectopia or hemiagenesis of thyroid. So this will be the way to for. Many experts differ in the suppose this child's FT4 level was normal and she has only a high TSH. So in that case, we would say the child has probably what we call as subnormal hypothyroidism. The baby is able to manage his hypothyroid stats by sufficient production of T4. So in such cases, if the baby's condition is not good, the advice is to start the child on the lower limit of the recommended dose of LT4, follow up with the pediatric endocrinologist, and estimate the levels of T4 as well as TSH in subsequent studies as advised. So you have to look at not only TSH but also T4 levels in the follow-up evaluation of the child. And also this exemplifies the importance of imaging in a child. I'll take a third case and then stop after that. A term baby was recalled after getting a screening result of mildly elevated TSH. It was 22, just above the normal. The confirmatory test done on day 7 showed TSH is 1.5 milli international units per liter, which is normal, and total T4 is 4 microgram per deciliter, which is on the lower side. How will you manage this child? So technically speaking, this child has low T4, but no high response in TSH. So the child most likely we can confirm one would be to a T4 level and confirm whether the T4 is actually low. If the T4 is low and the TSH also is on the low or normal side, then the child may be most often having a central hypothyroidism due to pituitary or hypothalamic abnormalities. The importance of this is that when a child has central hypothyroidism, they do not usually manifest with the classic features of hypothyroidism seen in dyshormonogenesis or dysgenesis. They manifest with the features of other pituitary hormone deficiencies. Isolated thyroid stimulating hormone deficiency is very, very rare. So look for features of central hypothyroidism. Commonest observation would be hypoglycemia, micropenis, midfacial defects, conjugated hyperbilirubinemia, or even sometimes polyuria. So look for these features and further evaluation will confirm the diagnosis. If the FT4 is normal and TSH is normal, then the story is the same as that of a preterm child that we discussed. It could be hypoproteinemia or it could be hypothyroxanemia due to TBG deficiency, which is a mild condition, does not need treatment immediately, needs only follow-up. So with these three cases, I am summarizing some of the common pitfalls and common difficulties in interpretation of simple algorithms that we provide for diagnosis and management of hypothyroidism by newborn screening. So to summarize, it is a common cause of preventable intellectual disability. Early diagnosis, early treatment, efficient follow-up can optimize long-term outcome. It is the only way to pick up CH in newborn period as the child is asymptomatic in his early days. And even NBS has its own limitations. Ideally, CH screening should be done between 24 to 72 hours with a dry blood spot on filters paper, and confirmation should be done by TSH and T4. Even if screening results are normal, you have to maintain a high index of clinical suspicion in a select group of children that are likely to be missed. Imaging studies are useful in deciding continuation of treatment and decision about long-term management. If you are going to start treatment with LT4, use it with as early as possible with the highest possible dose and ideally within the first 14 days. And you have to have a careful and regular monitoring for the success of therapy. If you really want to recheck, the ideal time would be after completion of 3 years of therapy for hypothyroidism. I hope I have been clear to you. Thanks for a patient listening. Thank you all. I would also like to invite Dr. Vijay Kumar and Riaz also to join me in answering some of the technical questions that could be there in the management.
CK sir.
Yeah. Yes.
Ranjit, please unmute CK sir.
Yes, sir.
Hello.
CK, sir.
The screen is okay.
Yes.
Thank you, Menon, for an exceptionally clear and lucid talk. And I think you have been interacting on this issue for several times. And you try, not fully, but almost. I have a question. The third is that, and you said we'll of toxin. What happened? Normally functioning thyroid tissue, when you put them on long-term, 3 years or so, thyroxine, does it affect its function Does it knock down this tissue during follow-up? What is your experience?
See, most of the cases that we are treating, these are congenital hypothyroidism. So
Yes.
these children, around 75% of them are those with dysgenesis. In those with dysgenesis, agenesis and ectopia are the commonest ones that happen.
Yes.
So in case of agenesis, there is no thyroid tissue there, so it does not come as a problem. The thyroid tissue is affected or not does not become an issue at all. In case of dyshormonogenesis, there is a goiter, there may be functional tissue, but it is bypassing the enzymatic methods. So it is not going to affect the child. In fact, it will reduce the goiter. So it will be favorable for the child in the normal development of the neck as well as that. The only question that can technically arise is that will giving L-troxin over a period of time can damage an ectopic thyroid tissue. That is the only condition in which the thyroid tissue is present, which is functionally normal, but is inadequate to support the development of child with adequate production of hormone. Observations are that these children with ectopic thyroid are not damaged. The ectopic thyroid tissue does not get damaged by L-thyroxine therapy. This has been proven by long-term studies. So L-thyroxine treatment actually helps in conserving the functional thyroid tissue by by denying the overdrive of the thyroid tissue. So it does not damage. The only damage that can happen is with the combined thyroxine as well as combined production of normal hormones by the normal thyroid tissue, the child can go into a hyperthyroid state. Theoretically, yes, but practically, the incidence of hyperthyroidism in such children by clinical manifestations or by biochemical evidence is negligible. But can it occur? Yes, by miscalculation, misadventure, parents can give medicine wrongly. For example, to give a medicine to a preterm child, the smallest preparation that is available is most of the places is 25 microgram. We do not have liquid preparations of thyroxine in India and in Kerala, but it's available in the rest of the world. So sometimes technically the child may be given higher doses of thyroxine by mistake by parents. So it can happen. And many times the parents may do something what we call as they forget to give the medicine, but when the time comes for them to come to the hospital to see to the doctor, then they suddenly remember and they try to give too much of medicine in one go in the hope that the test will become normal. So all these things can happen. But by and large, the neonate and the baby has a very conservative mechanism which saves them and protects them from most of the adverse effects of a dose of thyroxine up to 15 micrograms. So it does not produce a technical damage to the functioning thyroid tissue. Am I clear?
CK sir, unmute ചെയ്യാം.
അഷ്റഫ് അത് ശരിയാവില്ലല്ലോ.
ഇപ്പൊ ശരിയാണ് സാർ, കേൾക്കുന്നുണ്ട്. You are audible.
I am
audible. I think that is made clear. Thank you. This is something which was bothering me too long. Once somebody is starting on L-troxin and going on like that, will it affect a normally functioning tissue? As you said rightly, you start the L-troxin on ectopic thyroids, which is totally insufficiently producing the hormones. And naturally, the ectopic thyroid gradually go on regressing and sometimes it disappears. Thank you, Menon. Thank you very much. Next, Ashraf.
Yes, sir. Thank you, sir. Now, if there are any questions, you can send it to the chat box. We are not entertaining the direct question, but if any doubt or any clarification, all the audience can send it to the chat box. Dr. Vijay Kumar will read it out. Already there are several questions. As Menon sir said, Vijay Kumar as well as Dr. Riaz will join the discussion with Menon sir. Before going to the Vijay Kumar, please look at the chat box. Please be ready. Before that, I just call upon Dr. Shaji Thomas John for a comment and an announcement. Ranjit, please unmute chat, sir.
Yes, yes. Thank you very much. I think that is a very lucid and very informative talk. I'd like to state that we are running a clinic, and we have about 30% of these children having hypothyroidism at some point of time for the TSH and free T4. And even if it is normal, we follow them up till 3 years at 3 months, 6 months, 1 year, and every year thereafter. So that is the practice that we are following. So even if children with chromosomal abnormalities, they should be followed up, even if they are normal at birth, because the hypothyroidism in them could be missed clinically, and they can augment the intellectual disability that they already have. So this is from my experience. I'd also like to make an announcement that on Sunday, the 19th of, that's the day after tomorrow, we are having a critical care conference at the Criti Talk 2020, organized by the pediatric critical care of BMH and IAP KOZHIKODE and Kerala. We have speakers, Dr. Dhiren Gupta from Sri Gangaram Hospital, Delhi, and Dr. Rakshay Chetty from Rainbow Hospital, Bangalore. So I request all of you to please log in at that time. The message has already been sent. It will be from 9 a.m. to 11:30 a.m. Thank you.
Over to Vijay Kumar.
Good afternoon, sir. Thank you, sir, for that excellent talk. Everything is clear. And there are a few questions from the chat box. I think first question is, can you hear me, Ashraf?
Yes.
Yeah, you are audible. You are audible.
First question is from Dr. Harikumar. The question is, in a child who was found to have normal TSH level at newborn screening, is it necessary to do thyroid screening at a later age?
If the child is normal term baby with no abnormalities, no evidence of an associated chromosomal abnormality or a genetic syndrome predisposing to hypothyroidism, nothing is done. They are left and they are followed up as for any normal newborn or well baby clinic. If normal TSH in a term baby, if they say, as earlier person said clearly, if there is an underlying situation which can predispose this child to hypothyroidism. For example, the child had lymphedema and you are suspecting that baby may develop hypothyroidism secondary to Turner syndrome. The baby may have a simian crease, may not have telltale evidence of Down syndrome. So it is the clinical evaluation of the neonatologist or the pediatrician which will decide further course of action. There are clear patterns when the TSH levels are abnormal. Normal TSH, as I told you, can occur in a central hypothyroidism, and you may not even pick it up. And the clinical features of central hypothyroidism may not be a typical feature of the classical congenital hypothyroidism. So it all depends on the clinical examination of the baby. The baby is normal and is devoid of any additional features, then I would just leave the baby alone and follow up. These babies are followed up, not left alone, because they will be coming for regular checkup, for growth and development, and also for vaccination. So if there is an abnormality, it is at this time that the baby may be picked up. Well, is the practice different in Kerala? Probably Dr. Vijay Kumar or
No, sir.
Dr. Riaz can add on to
No,
this.
sir. No, sir. Same thing.
The reason
The
why
only only thing we have to be looking at is the central hypothyroidism, because all of us should remember that our screening doesn't detect central hypothyroidism. Because there was one case where I remember the TSH screen was normal, and that baby came with constipation to the surgery OPD, And as the screen was normal, nobody thought about doing a repeat TSH and T4. Actually, that particular child was having central hypothyroidism. It was detected a little late. So that is something we have to remember.
If you go through the review of literature on missed cases of hypothyroidism, it is very well known. Even normal TSH, normal total T4 has been reported in children with the dysgenesis in the screening. Sometimes it could be because it may be wrongly labeled or the samples have been replaced. So we do not know because it is being done with a non-personal touch in a central area. It is surprising that Dr. Ria's case had constipation. My cases actually of central hypothyroidism do not come with telltale evidence of congenital hypothyroidism. The baby had constipation, then obviously that it obviously looks like it is a mistake.
Sir, as Dr. Shaji sir said, any child with Down syndrome, we will do a newborn screening,
Yes.
repeat at 6 months, repeat at 1 year, and every year we have to repeat.
Yes.
Even Turner syndrome it is.
There are several other syndromes listed in the newborn screening. These are available in the standard protocols. Yes.
Sir, next question is that Dr. Rajesh Joshi from Mumbai,
Yes.
is the value of 20 unit which is used by Kerala as cutoff for TSH, whole blood or serum units?
It is
That
serum
is
unit.
in serum units. Actually, Dr. Parvati has already answered in the chat box.
Yes. It is serum units everywhere. Welcome,
Another,
Dr. Rajesh. Dr. Rajesh is professor of pediatric endocrinology at Vaiva, Garbhaivadia.
yes, sir.
Okay. Yes.
Another question is from Dr. Ananda Kesavan.
Yes.
How reliable is X-ray of knee joint? It will add or help when lab results are in borderline.
X-rays are not 100% specific, but it helps. In a doubtful case, it helps. There are several reasons why the abdomen, the X-rays may not show development of epiphysis or epiphyseal maturation. But problem is that conventional X-rays are not very diagnostic. I would take it as an additional point, but will not go by that alone as a diagnostic measure. Many a time it is picked up. For example, a baby undergoes a skeletal survey, and then you find an abnormal child with epiphyseal dysgenesis. In newborn screening programs, I have not seen babies with that type of abnormality. It is seen. These changes in X-rays are mostly picked up in untreated, longer standing congenital hypothyroidism. Those Vijay and Riyad, you can also add on.
Yes, sir.
Because
yes,
I
sir.
work
That
in
is
India
mentioned that
because of newborn screening was feasible and diagnosed hypothyroidism was very early in most cases. The old
sir,
cases of
X-ray.
dysgenesis that I
Yes.
have seen are in untreated cases it was in my early experience.
Okay, sir. Sir, for same for us also. So usually it is said that X-ray knee joint that indicates a severity of severe intrauterine long-standing hypothyroidism in utero.
Yes.
Sir, one question. Once we start at newborn period with 10 micro, how can we titrate the dosage per kilogram dose or based on the lab TSH and T4?
No, the kilogram based dose, the kilogram starting dose is the starting point. Starting point for the diagnosis. And then it also gives you an approximation when you calculate for the baby, whether you are going overboard or are under treating. However, since following the ESPE guidelines, which says that you have to recheck the value at 2 weeks, then at 1 month and 2 months, and then 3 months. It is very clear that they want to have the TSH touch the normal, upper limit of normal, and T4 should be at least in the lowest possible normal range. So the dose ranges are adjusted to maintain these values, but not allowed to go over this particular value.
Yes, sir. Next, from Dr. Richa Arora. When at 3 years we stop the therapy, do we need to do the scan even if TSS reports are coming normal?
Technically speaking, no, but I would be happy to do an imaging to know what was the underlying pathology so that I can explain to the parent why this child had abnormalities. It is it is not possible. I do not think that our methods of evaluation, for example, even scintigraphy or ultrasound cannot 100% diagnose the existing abnormality in all children detected to have congenital hypothyroidism on newborn screening. Some of them may miss. All these tests may not be reliable at all. Sometimes it is not possible to do a proper ultrasonography in these children. And I have seen discordance between reports where the ultrasonologist has said that normal thyroid tissue, normal parenchymal activity, normal echo texture, everything is normal. And then you do a technetium scan and you find the baby has hemiagenesis and other abnormalities. So they are complementary. And in my experience, I have picked up cases which I would have otherwise missed. So I believe that we should all do a screening, a diagnostic evaluation with imaging if available, because that will decide. If the TSH levels were normal with treatment, everything was all right. You discontinue treatment, 4 weeks later, still the levels are normal. You are not sure whether you would like to continue further or not. The evaluation by a nuclear scan definitely will tell you it is better to continue with a maintenance dose for some more time. So even many a time it will help in counseling the parents about the need to continue treatment. So this is important from my limited evaluation. This is an important step in the decision making for hypothyroidism.
Yes, sir. Actually, when I was with Raghupati sir, he always makes it a point whenever possible do an imaging, because he always says that we are asking a parent to give a drug to the newborn baby, and we have to have maximum evidence possible. So, if possible, doing an imaging even before starting the therapy, but always make sure that doesn't delay the initiation of treatment. So imaging, if possible done, will help us in having good compliance also, because in a child who is having agenesis, we are explaining to the parents that with the help of the image that this child has not developed thyroid. So we need to give the medicine lifelong. So such things are very useful if we can do that.
Excuse me, I'm Dr. Richa. I have asked this question. Can I?
Yes, please.
Hello, can you? My
Yes,
voice.
I can hear
Continue,
you.
madam. Continue.
Please.
Hello, can you hear me?
Yes.
Okay, okay. You are audible.
Yeah, my question is, when at three years we plan to discontinue because the thyroid is maintained and we are thinking that no, the child is not suffering. He has taken already 3 years. We have given him 1 month of gap. Okay, we will not be continuing the therapy. And now the TSH reports all are coming normal. And ultrasound is showing a scan, is showing a gland. But initially at the starting of the therapy, scan was not done because of some reason that child was started on thyroid initially. Do at 3 years, before I say, okay, you don't continue the therapy later on, do I need to do the scan or not? That is a query I want to
The
ask.
answer is still better to do a scan.
Better to do
a scan. Because after the child may be maintained and it may be a refractory period from which he will need time. And then it has happened to my colleagues that somebody had discontinued only to child to fall into hypothyroidism subsequently with milder symptoms. He picked up by somebody else. So then the blame comes to the person who has stopped the treatment.
Yeah,
See, that is the way we work. Unfortunately, that is the way we work.
Yeah, that is,
Nobody
yeah.
contacts and tells why you have asked, why you have been done. So I would advise to continue with, do a scan if you have decided to discontinue.
Okay. Thank you. Thank you.
Hello,
Ajomar.
sir. Yes. And suppose the ultrasound shows absence of thyroid, and suppose we have done radioisotope that also shows agenesis or ectopic, I think we have to continue treatment.
Yes.
There is no point in stopping the treatment for agenesis or ectopic. Is it true, sir?
Yes. If once agenesis is proven, you have to counsel the family that this child will need lifelong therapy. Even in heavy agenesis,
That these
it is
questions won't
believed,
arise.
it happens is that, like in ectopia, in many cases of agenesis also, the, the thyroid gland does undergo atrophy over a period of time. So it is better to maintain the dose of altroxin lifelong for all these patients.
Yes, sir. Sir, another question, what should be the cutoff value for serum value, as dried blood screening is not possible in our setup? That we have discussed.
The serum values, actually the cutoff values are still the same. There is no difference for most of the samples. What generally is done is that serum values are taken not for heel prick, but for cord blood, isn't it? But
Yes, sir.
if cord blood could not be taken and the baby could not stay, that is the only condition in which you will take probably a sample from a peripheral vein for collection. But the recommendations are the same as that for dried. But
So,
here the
so the,
sampling is done generally before 48 hours. And in that case, the cutoff before the 48 hours is 34 units and not 20 units. So it depends upon the time at which the sample has been taken. If the sample has been taken after 72 hours, generally the cutoff followed is 20.
so,
What is the Kerala practice? Kerala, are you taking
Yes, sir.
peripheral blood?
So we prefer to because in some small hospitals, if cord blood is not taken for some reason,
Yes.
then what we can do is we can take a sample after 48 hours.
Yes.
And because of this, to avoid confusion, we usually don't take samples between before 48 hours. That is, if the cord blood chance is missed, then we usually take after 48 hours. And the question of venous blood sampling arises because sometimes along with bilirubin, like on the third day or so, there is a practice TSH is also collected if the cord blood is not.
Next question is from Dr. Danya Narayan. Is thyroid imaging needed for all cases with abnormal newborn screening?
The Quebec and Pittsburgh group recommends imaging for all abnormal, all newborns found to have an abnormality. We are saying it is universal recommendation from Quebec and Pittsburgh. We are relaxing because of the non-availability of technical help in our situation.
Yes, sir.
That is why we have put up
Another
this
question. Yes, sir. Another question is from Dr. Shivaraman. Sir, if on follow-up of a newborn with hypothyroidism after 20 years, he requires more than 200 micrograms to normalize TSH, what does it mean?
I think it is, this question is out of pediatric field, but still, if any adult who is requiring more than 100 or 250 microgram of altroxin needs a re-evaluation. There may be a problem either with probably the level of control, number one. Number two, there could be a problem with the medication that he is using, and there could be other associated reasons for needing a higher dose of. It is very rare to find adults requiring, especially in the.
അടുത്തത് റിയാസ് വായിക്കൂലേ? അടുത്തത് മുതൽ കുറച്ച് റിയാസ് വായിക്കും. ഓക്കെ.
So I think he would need a re-evaluation for the need for higher doses. Any more questions? No. I am free.
Vijaykumar, even though there are some more questions, it is already 9:50.
Yes. Two or three questions.
Is it convenient to sir to continue?
I can continue, no problem.
Okay, Vijaykumar, continue.
Okay, Dr. Riyaz. Hello.
You are audible.
Yes.
Yeah. Dr. Riyaz. Sir, one question is from Dr. Manjusha.
Yes.
Sir, will thyroxine supplementation to mother in antenatal period have any confounding effect on cold TSH values? Should we repeat values after 72 hours even if cold TSH is normal?
No, the standard recommendation is no. Maternal medications, there are specific criteria for how to monitor for maternal hypothyroidism as well as maternal hyperthyroidism in pregnancy. There are standard set of guidelines are there. These guidelines indicate that if the newborn has normal TSH levels on screening, they do not need extra screening procedure. They follow the normal schedule. This baby will be followed up for development of evidence of hypothyroidism or late because of there is a chance that maternally transmitted antibodies can subsequently produce problem in a delayed rise in T4. Also, sometimes there could be associated hypoproteinemia because of the maternal disease. So, it is unlikely if the baby has normal TSH that the baby will need to do another TSH within the first 7 days or even the first 14 days. If there is an additional clinical feature, then the child needs evaluation.
Thank you, sir. The next question is, what is the best time to review with TSH and free T4 once we got a TSH of more than 20 in 72 hours?
The recommendation from ESPE is that immediate recall. If you can get the child within 24 hours, do the assay.
Yes.
That is what but the 7-day protocol that we are saying, not later than 7 days.
Yes.
Because if you do 7 days later, report takes still more time. You are not able to start treatment. If there is some difficulties, then 14 days period goes off, it becomes late. So if there is abnormal TSH in all established centers, immediate phone call goes for the baby to be brought back to the center. So it should be done as early as possible. And there should be a setup for this baby to come even at night and take a blood sample.
Yes. Thank you, sir. The message is as early as possible and not more than 2 weeks.
No delay more than 7
More
days.
than 2 weeks. Okay. And the next question is there a probable low value of TSH level during screening to suspect central hypothyroidism?
No. Even though there is no, it has been tried in some assay systems, it has been tried out. Thinking that the problem with TSH surge is that it is not predictable in all children. So when we say cutoff of 80, when we say that anything more than 20, anything more than 30, 40 was tried with a differential cutoff. And we know, all of you who have worked in this field know that anybody with a cutoff value more than 80 MIU per liter of TSH definitely has hypothyroidism. We were doubting whether if it should be cut off, should be brought down to 40 so that we include more people. Then we brought it down to 30. Then we brought it down to 25. Then we have brought it down to 20 now. There are several countries where the cutoff is 10, but their assays are extremely sensitive assays. The problem with the assays that you are doing in Kerala as elsewhere, for the assays used in the studies by Vellore, the studies used in AIMS as well as the Delhi multicentric assays, they are different. Their sensitivity is not as good. So when the sensitivity and specificity is low, you cannot predict a low level to use for hypothyroidism of central origin. It would not be fair. It would be better to go for the free T4 level, which are more sensitive in picking up these values, these cases.
Okay, sir. Thank you, sir. Ashraf, sir, can we have one
question
more
is-
question?
Yeah.
Okay. So last question. It is a few cases on follow-up will be showing normal TFT with a minimal dose of thyroxine by 1 year. So in these cases, can we consider a trial of stopping at an earlier age?
The experience in well-developed, in the best centers in the world is that discontinuing treatment before the age of 3 years, anytime, even for a period of month, and then later proven to be having hypothyroidism, had a deteriorating effect on the intellectual function. The best studies have come from Belgium, where the original recommendation when I was a postgraduate student was only continue treatment for a period of 2 years. Before that, the recommendation was for 1 year. Now you have to see that both USA and ESPE have gone from 1 to 2 to 3 now, because they have seen that there is a difference in the outcome of children who had discontinued treatment in between voluntarily or discontinued treatment on the advice of the treating specialist. And they have found that discontinuing for more than 1 month has had a definite deleterious effect on the outcome in these children when they were proven to have hypothyroidism. So the general advice is do not take that risk for the baby, because if there is a deleterious effect, you cannot reverse it. Any amount of L-troxin is not going to improve that. So the advice is, if the child has been detected to have hypothyroidism at least by 2 tests and an imaging study which has proven that there is an abnormality, do not discontinue, maintain the lowest possible dose to maintain the levels and continue till 3 years of age. These children do not develop hyperthyroidism.
Ashraf,
Sir.
and I want to make one comment.
Yes, sir.
In collecting the samples by heel prick, it is preferred to apply either liquid paraffin or coconut oil, because once you prick, the blood will come without touching. That is one. We have been practicing. The second point, what was the last issue discussing, I think I have told Dr. Menon some time back. A girl, 8 years old girl from Padi, she had been diagnosed hypothyroidism. Scintigraphy was not available those days and received L-troxin 3 years, stopped. 1 month later, TSH was estimated, that came 100. The same doctors restarted on L-troxin for another 3 years and stopped. Again after that, 1 month, TSH was estimated, that was 100. Then they reached me. So I did the basic workup, I did the scintigraphy that was showing dyshormonogenesis. As you rightly mentioned, stopping the drug doesn't end. They should be rigorously being followed up. One more point I would like to ask to younger generation pediatrician. You are screening, you should see the patient for follow-up at 6 weeks or immunization and some of the signs of hyperthyroidism, which you can EEG know how to diagnose. Anyway, that is an excellent. Thanks to see Menon again and again like this. Ashraf, you should call him again.
Yeah, definitely.
Sir, this is Dr. Rajeshwar Dayal from Agra. Can I just ask a small question, please?
Yeah.
Oh, welcome, Dr.
For
Rajesh.
you, Dr. Menon, an excellent presentation as always.
Nice to see you. Yes.
Thank you, sir. Just a small question. In older children, when suspecting hypothyroidism, it is essential to take this blood sample on empty stomach.
No, it is not essential. If the child has not been fasting, even then the older children, there would not be much of a difference. If you are doing good assays, if the assays are like a mealuminal clear or a very sensitive ELISA, it would not. But ideally, it would be 6 to 8 hours of fasting is good.
Thank you, sir. Thank you.
If the child has taken L-troxin, the tablet, then also we would say that better to do within 4 hours.
Right. Right. Thank you, sir. Thank you.
Thank you. Thank you. Nice to hear your voice and see
Pleasure,
you.
sir. Pleasure.
So
Pleasure.
with that, we will conclude the session. Thank you, sir. That excellent narration of the story of neonatal thyroid screening, with stressing some of the most important practical issues as well as the concerns. And most importantly, the surveillance of these children, importance of the surveillance of these children, neurodevelopmental outcome, and the clinical follow-up, the growth and development, along with the biochemical follow-up. Thank you for that excellent session. Thank you, CK sir, for chairing the session with the nostalgic memories about the AMS days. And thank you, Riaz and Vijay Kumar, for the active participation in the discussion. Now over to, we will call again and again, Menon,
Yes.
sir. Never get an opportunity. Now over to Dr. Nihas for a word of thanks.
Thank you, sir. Thank you, Menon, sir, for coming again to Calicut and giving us, getting us through the complete spectrum of thyroid screening and treatment. Thank you, sir, for coming again. And thank you, CK, sir, for being always with us for all the meetings and sharing this session today. Thank you, Riya, sir, and Vijay Kumar, sir, for actively taking part in the discussion. I thank our state OB, Narayan sir and Bala sir for all the support. Andhageshwaran sir and Ramesh sir for being there every day for our sessions and being a part of it. And all the seniors who joined us, Shaji sir, Latif sir, all others who joined us today for this meeting. I have 3 announcements for the next 3 days. Tomorrow we have the PG Club, which is a session by Dr. Lulu Matthews. Madam is taking on OSCE. Nothing great about it. Is the topic name. So it is at tomorrow 5:30 p.m. And on Sunday we have, as Shaj sir told, we have the Kriti talk. That is from 9 a.m. to 11 a.m. Also along with it, we have a Kriti quiz for the postgraduate students. So I request all seniors to encourage the postgraduate to take part in this quiz. The quiz is having a first prize and second prize, which is cash awards. And on 20th, that is next Monday, we have the next session of Meet the Doyens. That is by Dr. Raju P. Kubchandani. Topic is on autoinflammatory disorders. That's at 8 p.m. Thank you all for coming today, and expect all of you in the next sessions also. Thank you. Good night. And thanks to Ranjit again. I forgot it. Ranjit, thank you for hosting this meeting. Thank you.
Thank you, sir.
Thank you. Bye.